Hello, my name is Miranda Hester with Contemporary Pediatrics, and today I'm speaking with Dr. Andrew Schuman, who is a clinical assistant professor of pediatrics at the Geisel School of Medicine at Dartmouth and also a practicing pediatrician, about how telehealth is working out 2 months into the COVID-19 pandemic in the United States. So, Dr. Schuman, now that you've done both telephone and telehealth visits for 2 months from home, can you compare the two in regards to effectiveness?
Very good question, Miranda. Pediatricians are used to interacting with patients via telephone for years, decades. It's our traditional way of providing care to patients. And interestingly enough, it's services that we have provided free of charge. That's another question we'll need to explore in the future. But if you need to communicate small bits of information, telephone communication is more than adequate. And ideally, to mimic a real in-person visit, you'd like to do a telehealth visit. There are many advantages in virtual video visits that are not present in telephone encounters. It's very important for physicians to interact and see facial expressions, to see how their recommendations are received, to perceive attitudes among patients. So the telehealth visit is in many ways superior, but not necessary. And in my own practice, I've found that it depends on the need of the patient, their technology capability, the software that your practice is using. So there's there are many factors that go into the decision which to use, but both have their advantages as well as disadvantages.
Right. So, do you have any new recommendations for selecting a telehealth service?
Yeah. I do. Months ago, you recall that we had another interview where I was giving recommendations to pediatricians who many of whom were, and perhaps many are still naive regarding implementing telehealth in their practice. There are many platforms available. The one that my institution uses, patients continue to have problems with because they have to download applications, put in passwords, and so forth. And there's lots of glitches that make, easily 50, 60% of our telehealth visits ineffective. So I've done a little research and I find that there are two apps that I like to recommend for first-time telehealth users. One is DoxyMe, which is inexpensive and is a web-based application. And pediatricians, primary care providers can just enroll for a reasonable fee. I think it's $35 a month per individual. And you merely send a link to a patient, they click on it, and you're there in a reasonable, good quality video visit. What's perhaps even more easy to use is a new application from Doximity, which at the moment is a smartphone-based application. You launch the application and you do nothing more than put in a phone number and send a link to the patient. They click on the link and you're there. It's very simple, straightforward, and it just works. So the majority of my calls these days are by way of the Doximity app. So I think in terms of technology, simple is probably better at the moment. Once we emerge from this crisis, this pandemic, then one can decide what platform you want to use. It will depend on reimbursements and a number of different factors, but we'll have to see what happens.
All right. So, during the pandemic, have you seen a change in your management of ADHD patients and those patients with anxiety and depression via telehealth?
Yeah, I have indeed for a variety of reasons. Patients are home with their parents are home with their children, and parents had the opportunity to observe firsthand the activity level and the focus of their children. Whereas before the pandemic, they were getting reports from the teacher who had to pay attention to 20, 30 kids. And now parents know firsthand if the medication is effective at the dosages we prescribe. It's also a very stressful situation for parents and children. So I've had to initiate medication and recommend video counseling for a lot of patients. I've had to adjust a lot of medications to more suit the environment that we're seeing in the midst of the pandemic. So it's very interesting.
All right. So, do you have any new recommendations regarding deciding whether to prescribe antibiotics during a telehealth visit?
Yeah, I do. When we started this interview series, I made some general recommendations and made the observation that pediatricians who have been doing pediatrics for a number of years have acquired a skill set that enables you to look at a patient and without touching the patient, determine many things, whether the patient has respiratory distress, is the child really sick or not? And these are the basics that we know. But over the course of many weeks, I've been surprised how few antibiotics I've prescribed, and perhaps a few tips that I'm revealing in an article that should be published next month in Contemporary Pediatrics. So, high quality video visits are ideal. As you know, it's easy to diagnose certain things by video, including certain rashes like impetigo, diaper rash, conjunctivitis, and so forth. I've been very surprised how well one can visualize the throat of a patient by video to the point of looking for tonsillar hypertrophy, exudate, and so forth. While one cannot auscultate the lungs, you can look for signs of respiratory distress. Audible wheezing is very apparent. So there are lots of things pediatricians can do to continue to prescribe antibiotics judiciously. So obviously conjunctivitis and rashes, some of which need an antibiotic prescribed to resolve the infection. You cannot do a strep test, remotely, but sometimes symptoms and signs of sore throats indicate whether the patient may be at risk for strep or not. If a patient has a cough, then it's unlikely that it's strep, but ultimately it's your decision to err on the side of caution and prescribe an antibiotic. I think the most challenging is the febrile patient with a cough. You need to, of course, eliminate COVID as a possible cause. But in that instance, particularly for an asthmatic child or one with some early signs of respiratory distress, I've been erring on the side of prescribing antibiotics. The last thing is, if someone complains of ear pain, then if a child's able to do a Valsalva maneuver or equivalent, that is, if they can blow a whistle, if they can blow into a party horn, or actually do a Valsalva if they're old enough, if there's at least fluid in the middle ear space, they're going to have pain with that maneuver that would lead me to believe they have a middle ear process going on. And in that instance, I would tend to prescribe an antibiotic. So it's a surrogate, not ideal, but these are the tips I've kind of acquired over 8 weeks of doing video visits on ill children.